Hi, thank you for inviting me here to talk about our work at Sunnybrook Hospital. Just find my clicker here. Here I'm representing a team from Dr. Meng Price and Dr. Lipsman's lab. So we work with Insightech's device to open the blood-brain barrier using focused ultrasound and interaction with microbubbles in the brain. We think there's a great promise in using this technology for patients with glioblastomas and malignant glioma. So one of our first studies was looking at this patient population to demonstrate the safety and feasibility of MR-guided focused ultrasound blood-brain barrier opening in patients with co-administration of the chemotherapy. So the study design was that the patient would come for one session with administration of chemotherapy, and the day after they would get a resection of their tumor. They would continue to follow up for 3 months, and during this period they would resume their standard of care with their neuro-oncologist. Intraoperatively, our design was a 3x3 size grid that's approximately 9 millimeters in each dimension and 7 millimeters in depth. And we plan to do as many as we could around the tumor, and our sonication parameters are illustrated there. So our patient selection were patients who have a previously diagnosed, so a pathology report of high-grade glioma, or a new presentation suspected of being a high-grade glioma on neuroimaging. These are some of the other inclusion-exclusion criteria. Our outcome measure of interest were safety and feasibility. We wanted to qualify the number of adverse events related to the procedure, and for feasibility, we looked at T1 weighted MRI with gadolinium extravasation as a surrogate for B permeability. So here were our 5 patients. And their pathology report from the resection. All of them had high-grade gliomas, and the chemotherapy that was delivered just prior to the MR-guided focused ultrasound procedure. We had made a switch from doxorubicin to temozolomide, basically to conform to more of the standard of care that's being offered to GBM patients. So we found that the procedure was fairly well tolerated. Here's just, didn't show very well. The yellow square is supposed to enlarge the little square. Anyway, you can see that there's a clear 3x3 grid that we were able to demonstrate in the area of sonication. And basically the table describing the volume of sonication, BB opening that we were able to achieve, and the contrast enhancement differences. Also of note, the sonication power was very low compared to the use of MR-guided focused ultrasound for things like neuroablation, which may be about 100 times the power used for BB opening. So here's just another demonstration of the closure of the blood-brain barrier. So we're very interested in not just opening, but the ability of the blood-brain barrier to heal and close. So a day after, we had the patient undergo another MRI scan, and we were able to show that around the area where we saw the contrast extravasation, it is now resolved. So in conclusion, we gathered preliminary safety and definitely technical feasibility data with this technology in patients with GBM. They were very well tolerated, and there were no any serious adverse events related to the procedure. So some limitation, it being a fairly preliminary, small unblinded study, but we're hopeful that with the design of more complex designs and multiple treatments, that we're able to show some measures of efficacy as well. Thank you. So just want to acknowledge our collaborators and our funding agency, and as well as Gary and Ruby, our technicians. So thank you very much.
Other questions? Are you stepping up for a question?
Do you have a proof of, I'm on your right.
Oh,
Here.
I'm
Over
trying to
here,
find
right
you. Oh,
Do you have a proof of drug increased delivery? Because this is a goal to do it right before surgery, I guess.
yeah, exactly. So I have it on my poster, so kind of a shout out to my poster next door. But so yeah, we did quantify by mass spec the amount of doxorubicin or temozolomide that was delivered. So in some patients we weren't able to adequately sample. That was a major limitation to that aspect of the study. But it looks like the levels are increased, but the numbers are so few that we can't really draw any conclusions.
I've seen the
that
poster.
right now.
Well, the fact is, maybe because the drug is, the surgery was performed 7 days after?
Yes, exactly. That's another aspect, that it is 24 hours. So ideally, animal studies, animals are sacrificed right away, so you do see a big difference.
And I think that the problem with phase zero concept like this is that when you're measuring the drug inside the brain, actually you're measuring also the drug inside the vessels. And you cannot make the washing you can make on animals. So you don't know what is a part of what goes in and what stays in the vessels.
Very good.
That's a great study.
One last question.
Okay, quick question. Do you do any biochemistry on the tumor once it's resected? For instance, 0,6-methylguanine DNA methyltransferase with temozolomide, to see if there's damage being done and if there are repair pathways in effect that might confound the results?
Confound the results of like safety or
No, in terms of repair of
Yeah.
the drug,
Okay.
the drug damage.
So I guess, first of all, I just want to say that, the message here is that this study wasn't designed to demonstrate efficacy. It was really safety and feasibility in mind. But that's a great suggestion. One of the first challenge is actually measuring the drug itself, and then further along, we would obviously look at, downstream markers.
Oh, I appreciate that part of it. I was just wondering if you have the tumor samples sitting out anywhere, frozen away, or saved in paraffin.
So tumor samples were just sent for pathology analysis right now. No, not in those aspects, but that'd be interesting to look at.
Okay, thank you.
Thank you. Thank you.